Hi, good afternoon. My name is Ricardo Cahigas. Today we're going to be doing a thoracic um, and lung assessment. And this is my patient. His name is Tony. Um, Initially, we will begin the inspection um, by visually inspecting the patient. We'll be looking at, again, when you're doing a thoracic assessment and lung field assessment, you just want to look at the actual rise and fall of the chest wall. Look at the rate of breathing that the patient is having. Prior to beginning the assessment, what you want to do is look at the patient's medical history and physical. For example, you're looking for signs that the patient has asthma, any type of structural kyphosis, or bending of the back, or structures, anything that would indicate that you need to focus on during the course of your exam, or you may want to look at during the course of the exam. But again, for a normal patient, what you'll be looking for is looking for the visual inspection, looking for the rise and falls of the patient's chest, looking for intercostal muscle, use of the intercostal muscles during the course of breathing. Again, you're observing inspiratory and respiratory respirations. You're looking to see if there's any tracheal tugging. Is the trachea midline? Again, the normal rate of breathing for an adult male should be between 12 and 20 breaths per minute. Again, during the course of your physical exam, you're asking them questions. You will assess and see whether the normal speech pattern, whether they're short of breath, having difficulty speaking, or anything of that nature may indicate something during the course of the exam. Again, what we do is just move towards palpation. And again, what you're looking for, the patient demonstrates any pain or discomfort during the course of the examination. Also, you're checking for any crepitus, subcutaneous emphysema, things of that nature, anything out of the abnormal during the course of palpation during your physical examination. And again, you're doing a comparison from one side to the other. And again, the trachea, you're just checking to make sure that it's midline, checking from one side to the other, checking between the intercostal spaces. And again, doing a comparison between one side and the other. Again, you just going to ask the patient, have any pain or discomfort, anywhere you touch, again, that would indicate any signs and symptoms of something that may be, be brewing, or something that may be worried that you have the examination continue further assessment. During the course, we would do the percussion exam, and again, we would do it more. You should do it during the anterior and the posterior portion of it. Again, what we'll be checking for tactile phrenitis, which would be the transmission of the voice or sound through the lung field to the chest wall. So when you're doing tactile phrenitis, just use the palm of your hand. And again, what you're trying to feel for is see if it's equal on both sides. When I say the palm, I actually mean the side of your hand. I'm going to say 99, Tony?
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Thank you. And again, you want to check between the intercostal space. You want to try it not to be above the bone. Not to be on top of the bone, because then you're going to get a false transmission at that point. Again, when you're doing an auscultation, you want to start on the upper anterior portion of the lung, upper lung fields. You want to start above the clavicle. Take a deep breath. Just exhale quickly. In and out. Again. Again. Okay, good. And again, you're listening for equal lung sounds bilaterally on both sides of the lung fields on the anterior chest wall. We would just actually demonstrate direct and indirect percussion. And again, with just a slight palm of the hand, what you would do is just listening and feeling for resonance. Again, it's a dull sound. For indirect, you would just use your third index finger and the second, the IP joint. And again, you're going to be listening for resonance. Again, go within the intercostal space. And again, it should echo on the lung fields. When you get to a bone or other structures, it will sound like a dull sound. And again, that could be normal depending on what you're palpating on. But if you're looking for the lung fields, when you're listening and looking for the lung fields, if you hear a dull percussion, probably indicates some signs and symptoms of consolidation. Again, I'm going to turn you around. Okay, when we're doing the posterior portion of it, again, we're going to be looking again for the rise and fall of the patient's chest. Take a deep breath for me, Tony, a little bit exaggerated. And again, in and out normally. Again, you're looking for the rise and fall of the chest. Looking to make sure that there's equal expansion of both lungs. Take a deep breath. Good. And again, your hands and thumbs should move up symmetrically. And we're going to be doing the same thing. Again, Tony, 99.
99, 99, 99, 99,
Stop. Now, just when you're doing checking for phlebitis at this point, what you want to do is just avoid going over the scapula here, because obviously you have bone. You're going to get a different transmission. So 99, Tony.
99, 99, 99, 99, 99, 99.
Thank you. And again, when you're just doing the percussion, also, you just want to make sure that you have to take the don't do a percussive over the scapula, because you're going to get a dull sound, and it may be a little bit sleeping. It's very difficult to hear here, but I try to exaggerate it somewhat. But again, it doesn't resonate. It's a dull sound. When I go here over the lung field, it sounds a little more echoes. And again, as I move down, what I'm trying to do is just map from one side to the other where the lungs are. And again, have a visual map. Again, you have the vertebrae. And again, during the process of percussion, you start to see from an anatomy that we're all familiar with, but also through percussion and listening to lung fields, get an idea of the lung sounds mapping. Again, we're going to auscultate from one side to the other. Take a deep breath. Good. Again. 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 Good. Now, what we're going to do is just go over diaphragmatic excursion. Well, again, normally when we're doing our percussion, what I want to ask Tony to do is just take a deep breath and hold it. Take a deep breath, Tony, hold it. There you go. That's where it's right here. There is dull. There I get resonance. Okay, so that's the bottom of the bases, and I'll go to slightly above. There you go. Okay. So we know here. What I can do is just go mark it with a pen. That way I have the baseline of where it starts. All right, Tony. Just go ahead and exhale and hold it. Take a deep breath. Go ahead and breathe normally, excuse me. Okay, I'm going to actually take a deep breath. Take a deep breath. Blow it out. Okay, hold it. And what I would do is just start from here. And again, I get that same difference of resonance here, and that's the diaphragmatic excursion. You're going to breathe normally. And again, what you were looking for is usually between a 3 to 6 or 7 centimeter, 3 to